Partial knee replacement or unicompartmental knee replacement remains to be one of the hot topics in research up till now. And this is an example that more than 300 papers has been published through the last few years. There is enough evidence to demonstrate that UKA offers a good medium to long-term success. But three conditions has to be around. If they are not available, failure will be the end result. And this is a very important slide which we'll go and repeat through the next 8 minutes. The start with the first one, correct patient selection. Evidence shows that around 10% of osteoarthritic patients present with unicompartmental OA. Not all of them are symptomatic enough to accept surgery, and almost all of them are not symptomatic enough to accept surgery in Egypt. And we have seen through the last few talks the x-rays of the people who come for us asking for knee replacement in Egypt. And to understand this more, we will go through the indication and contraindication of the uni, and we will focus on the contraindication. And as you can see, bicompartmental, fixed flexion deficit, more than 10 degrees varus, more than 5 degrees valgus, morbid obesity, almost these four are present in almost all the patients who comes to us asking for knee replacement. This is the kind of patient which is expected to come to ask for a replacement for a uni, and this is the kind of patient we tend to see in Egypt asking for replacement. So definitely there is a big difference between them, and it's very obvious that the contraindications are more or less all present in our population. So you come across two options: either to broaden your indication and you start risking failure of your uni, or to go yourself looking for your patient for uni. And we will go back to the evidence. We will find that even if you find your patient and you do uni, is it really something which is better than total knee? Is it something which is worse, the more expenses and getting your patient at risk of having an early revision? You will find that most of the papers are comparing oranges to apples. So comparing an active patient, young, with some pain, who gets a uni to be very active and happy, to a patient who is crippled and gets a total to be active or mobile. So the end result is that very active, definitely is not the proper way to compare between both of them. And this is not my impression. This is the impression which has been raised in the Journal of Arthroplasty since 2015. Unicompartmental, does a selection bias exist? And the conclusion came that there is not only a selection bias, but also showed patient converted to TKA intraoperatively had similar clinical result to patient receiving UKA. So if you get the population you are asking to get an UKA and you do for them total knee, they get the same good results. And another very recent publication in the Journal of Arthroplasty concluded that when doing a controlled randomized trial of partial versus total, so they pick up the same population of patients to compare, they came to a conclusion that there is no clinically significant difference between both of them as regard early post-operative period, patient-reported outcome, duration of opioid, or return to work. So UKA is successful because of patient selection, and I don't think that this type of patient exists in Egypt. And at the same time, you will get your patient in risk of inferior survival rates, as the evidence says. We go to the second condition, which is a prosthesis design. And I am here quoting the manual of one of the very successful UKA implant here. And astonishing enough that you can see that the indication are only 2 sentences, and all the rest of the page are contraindication, warnings, precautions, possible complication. And continue in the next page. So indications are limited to 2 sentences, and all the others are warning you about what can happen if you don't do the UKA right. So you come to across either 2 things. If we don't have enough now, or the best design for UKA yet, or that this company is blaming, or all the companies are blaming the surgeon, and they are warning the surgeon that they will get a bad result if they don't do what they should do. So this will take us to the next and the last one, which is implantation technique. So what is the evidence saying? The evidence saying is it is a specialized procedure which works well in the hands of experienced operator. So not for all the knee arthroplasty surgeons. And the requirements are high volume surgeon who does a lot of uni, patient specific instruments, computer guidance, robotic assistance. So all the new papers are talking about getting a more and more expensive surgery to do the uni, which I don't think we have the finances here in Egypt to get it. If we go to the high volume surgeon, there is a very important publication recently published, which is stating that low percentage of surgeons meet the minimum recommended unicompartmental knee arthroplasty usage thresholds, analyzing more than 3,000 surgeons in 3 big countries, UK, Australia, and New Zealand. They put the threshold in as 12 UKAs yearly, and I don't think we can get here in Egypt 12 UKAs yearly. And they came to a conclusion that the majority of experienced knee surgeons are not meeting the recommended minimum thresholds in these 3 big countries of arthroplasty. So to conclude, partial knee replacement is not for Egyptian patients and not for most of the Egyptian orthopedic surgeons. Thank you very much.